Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hey everyone, and welcome back to Research Perch. I'm Michael Reynolds from the Marketing Committee of the Massage Therapy Foundation. We're glad you're here. Research Perch is, as you probably already know if you're a loyal listener, designed to unpack articles from the International Journal of Therapeutic Massage and Bodywork and bring them to you in a hopefully more lively format. In a very conversational format with Ruth and Nikki. So we're joined as always by Ruth Werner and Nikki Monk. Ruth, how are you?
I'm great. How are you, Michael?
Doing excellent, thank you. I've got a new 6-week-old baby, so I'm just beaming.
I know you do. It doesn't look the least little bit like you.
And Nikki, how are you?
Doing great. Thanks, Michael. Congratulations.
Awesome. Thank you so much. Glad to have you both, as always. So I want to give a little shout out before we get started on this episode, just because one of our volunteers on the committee, Ryan Hoyme, has been graciously starting to produce these videos for us. So he's kind of tag teaming with me, and he's been very helpful in producing the video component to Research Perch. So just a big shout out to Ryan Hoyme and all he does for the massage community and for the foundation. So thank you, Ryan. We appreciate that.
Thanks, Ryan.
All right, so let's get started. So today we are talking about, this is an article obviously from ijtmb.org, and it is Massage Impact on Pain in Opioid, it's a hard word to say, opioid-dependent patients in substance use treatment. So first off, what is an opioid-dependent patient?
I'll get this one launched off, Nikki, if that's okay?
Uh-huh.
All right, so one of the things about this study is that it was partially funded with a grant from the Massage Therapy Foundation, so we're always happy when these things come to fruition. An opioid-dependent patient is someone who has become addicted to opioid medications, usually things like OxyContin or similar drugs. And in this study, the population group were people who had become addicted to opioid medications because they began with some chronic pain situation. And that made them, it made them a particularly interesting group of people to study to see if massage therapy could, create some kind of positive impact on their pain and functioning levels. So that's where we began. The goal of the study was to consider the efficacy of Swedish massage therapy in reducing pain in people who are opioid dependent, who had chronic pain, and who were receiving methadone treatment at the time.
And correct me if I'm wrong, Ruth, these were folks that were former heroin addicts, right? They were using heroin and they're in substance use treatment. Was it they were on methadone to come off of heroin, or no?
Oh gosh, you know what? I have to go back and look, because my understanding, Nikki, is that they began their dependency because they started with chronic pain. Whether that went to heroin use or not is an open question for me. I'd have to check. But my understanding was it's just opioid medication.
Okay. Well, I think it's really important to couch this population that they're looking at within the context of primary care and what's happening in pain treatment with primary care. And this is that they're finding that the opiate dependence is becoming very, very problematic, and not only opiate dependence and abuse, if you will, but then also the side effects and things that happen with continued and chronic opiate use, and then also the overdoses and all of these things that we are hearing about in the news and everything. And there's big movements afoot in primary care to reduce prescription to these opioids, and or to step folks down from higher doses, higher dosing. And the problem that physicians are running into from an ethical perspective and then just from a treatment perspective is this tension between wanting to keep their folks safe, but then also being able to give them something that is effective for their pain in the interim, right, or in substitution for opiates. And there isn't much out there for them. And so this is a challenge in primary care, this is a challenge in research and all across the mark. So this is a really important study from a massage perspective. And as you say, this was to look at how massage could impact the pain levels. So it wasn't about decreasing medication usage or anything like that, although they did measure some of that through electronic medical records. but it is looking at pain in this population.
Well, yeah, all right. So let's list the outcomes that they were looking at, and the point you make is extremely well taken. You know, we have a lot of ideas about the effectiveness of massage for various kinds of pain or pain in various kinds of settings. You know, if we can demonstrate some effectiveness for massage as an alternative to opioid-based medication, my goodness, that would, you know, that opens many, many doors, not only for our profession, but for the people who really need a non-pharmacological solution to, you know, to these difficult long-term problems. The outcome measures that they were looking at in this study included pain, anxiety, depression, physical functioning, substance use, and improved treatment engagement. Those were the things that they were looking for altogether. But of course, the main one is looking for self-reported pain.
Mm-hmm. Well, and then also they're looking at improvement in satisfaction. So this patient global impression of change.
Right.
So it's basically, and this is compared to the past month. You know, how much better are you doing? How much do you perceive that you're doing in relation to pain? But then there was also a really interesting thing that they asked about, and this was a question sort of getting at this idea of what their expectations are and their self-efficacy. And this is, do you think you can ever be pain-free? Yes or no?
Which turns out to be, for the results of this study,
very
the most interesting question.
Right. So they ask that question, and then they also ask from a qualitative standpoint, from a descriptive standpoint, what would it take to get you pain-free? Mm-hmm. And some of the answers from this population are very heart-tugging and are very sad.
Yeah, I you know, since I read this, I was saying before we began our recording today, since I read this, I've been referring to this article in some of my research literacy classes, and it's, you know, sometimes it's hard to get through it without choking up a little bit because the findings are so human. Mm-hmm. Not abstract and not distant from what we do.
So, talking about the trial, looks like Swedish massage was applied, right?
That's what that was the standard that they used.
So let's talk about the design of the trial here right quick. This was a randomized controlled trial, and what they did was they identified a number of folks that were within this substance use treatment. Okay, and so all of these folks were going to be attempted to be contacted to be enrolled in the study, and they had a pretty clear set of inclusion criteria. But from all these folks that were in treatment, they invited them to participate, and then they were excluded if they were on complicated medications or had neurological disorders, things like that.
Or things that would contraindicate massage.
Right, contraindications. And then once they came in, they collected their baseline information, and then they randomized them either to a massage treatment group or to a
treatment as usual.
Right, so a TAL group. Both of them got treatment as usual, but just one got the massage. The massage intervention included 8 weekly massages. Those massages were 50 minutes in length. And it's important to note here that these massages were a very standardized treatment. So every time they came in, and every person, regardless of the origin of their pain, got the exact same treatment. There were 4 different massage therapists who provided these treatments. Women massage therapists worked on the women participants. Men massage therapists worked on the men participants. And I think it's a really interesting thing to note why that was for this population is because of the amount of folks who were participants who had engaged in trade of sex for money.
Yeah.
That, they kept that gender separation. So they collected data at baseline, at halfway point in the treatment, so at 4 weeks, and then after treatments were completed, so 8 weeks, and then they did a 4-week follow-up.
Right.
Yep.
I love it when you get that 4-week follow-up because it gives us some sense of durability of effect.
Right. Yes. So it does do durability there. Mm-hmm.
So Nikki, I don't want to rush you if you have more to share on the trial, but what was are we ready to kind of talk about the outcome?
We can. Ruth, do you want to hit the highlights of this?
Sure. The outcomes weren't good.
That's kind of what I'm seeing too. I'm kind of
Yeah,
curious.
the outcomes were extremely disappointing. The massage therapy group within the massage therapy group, they had some improved pain scores, particularly for the people who reported really extreme pain to begin with. But the improvements in their scores were not terrific. There were no improvements reported in the other measures about treatment engagement or anxiety or depression or physical functioning. There was only one subgroup of all the people who participated in this who reported, consistently good outcomes related to having received massage.
Or clinically meaningful outcomes.
Say it again?
Clinical meaningful outcomes.
Clinically meaningful outcomes, thank you. And that subgroup, the only group that really felt like they had some clinically meaningful improvement, were the group who answered yes to that question, do you ever think that someday you could be pain-free? Mm-hmm. And, I'm doing it again. To me, that is, that speaks to so many important things about healthcare, about hope versus despair, and about the nature of the client-therapist relationship. Even though that aspect, all right, so the nature of the patient-caregiver relationship. If we can, I'm probably getting way ahead of myself at this point, but I'm already sort of off into what does this really mean? Because what this really means to me is that the first step in working with people who are in chronic pain and in this really terrible situation is to bring them to a point, or help them get to a point where they can see that maybe possibly someday there's a way out. Because if they don't get to that point first, the chances are good that the treatments, regardless, are probably not going to be effective. Massage therapy is finite in its effectiveness. It won't turn a person in despair into a person who has hope unless they have other things in their life that are pointing in that direction. So that's, I just was so moved by the fact that it was the people who had the capacity to see a future where someday they're not in pain, who were the ones who seemed to be most able to feel a positive effect.
Well, and these were the folks that had changes in their numeric pain rating scale of clinical meaningfulness, which is a change of 2 points. Mm-hmm. What I think is really interesting is if you look at figure 3, this is the series of bar graphs with this. This is talking about the perceived changes and their satisfaction of perceived changes. And they look at this between the massage group and those who had usual care. And they do this in a really interesting way. They start and they do these comparisons, and this is all descriptive. They do some chi-squares and things like that, but I think looking at these graphs are really, really very telling. And so at baseline, they are indicating that at baseline over the past month they have had no changes in their pain. Okay, both groups. Mm-hmm. But then after the intervention has started for these folks that are getting the massage, while a majority of the folks in the treatment as usual are continuing to report no change, those who are in the massage group are reporting some minimal improvement in their pain levels. And those that are experiencing no change has gone way down. In fact, that's like 15% of folks have had no change. So there has been some change, and it's looking like over 60% have had some minimal improvement in the massage group. And then the next 4-week session, so at the end of it, over the past month again, those who didn't have massage, no change for the most part, and still again, minimal improvement for those who had the massage, and there's a nice little bump up in the much improved and very much improved group. Mm-hmm. And so it's this perception of improvement that they're also charting here. But now you go to this follow-up section, right? And here again, it's staying consistent for those who are in the no treatment group, no change. And in the massage group, now there's a shift from the no change to the much worse. So massage has been withdrawn from them. They're asked how they've done over the past month since that's happened, and now they've gotten much worse. So this is from a descriptive standpoint, this is really very interesting, especially when we're thinking about a curative versus a maintenance and a management of a chronic pain situation.
Right. Good point.
And it's also really important to keep in mind the context that this population brings. These are folks that are actively receiving methadone treatment. This addresses pain. This shifts the way that they're already experiencing pain. These folks have a dependency. Most of them, I can't remember the percentage, they started having this opioid use, however they were taking it, because of chronic pain situations, right? And so it's really hard to say that the way that the methods were set up and the way that they were measuring things, all is not lost here. The takeaway point of this is not that massage isn't effective in these groups.
Right.
Because there is some effect here. What they are perceiving as effective is being measured. Now, they didn't measure if the amount of methadone that they needed was decreased. Or actually they did. They said that there weren't any changes within the groups. But that wasn't the targeted outcome, right?
Right.
If there was a group, if you started looking at this and can we help people who are trying to come off opiates and find something else, if they started receiving regular massage treatments, would they be able to better manage a stepped down approach for those in the population that are willing to do that? Because you've got this tension too of folks that are dependent and all of the pieces that go along with that. And so you look at this group, and they talk about this in the discussion. This is a group that are mostly homeless, who are marginalized overall. They have this dependency issue as well, and that's a very different kind of population than, say, somebody who goes to their doctor and says, I think I have a problem, I'm having these really bad side effects, I want to come off of opiates. Can we try something else? And this goes to the place of their willingness to try, their self-efficacy, and things like that. So all of these things really have a very dynamic effect and interplay. And it's really important to keep in mind when we consider things like this. This is a great pilot study. It shows that you can do this kind of treatment in this population. The fact that almost 85% of the whole participant pool completed all of their sessions.
That's big.
That's big. And so they've got a really good proof of concept that this is a viable way that we can study massage therapy in these populations. They've done a really nice job documenting that and showing that. Yeah, so I have another point, but of course, as usual, I've spaced it, but I'll come back to it in just a second. I'm going to let you know on those pieces.
Well, Nikki, it sounds like you think there's more work to be done here.
Oh, absolutely, there's more work to be done. And here's my other point. This is it. So, like we mentioned before, this was a very specific and standardized treatment.
Right. I was going to bring that. I was going to bring that in.
Good. So why don't you take that piece over, and then I'll add anything else at the end.
Well, all right. So if we got these sort of tiny incremental self-reports of slightly reduced pain, with a standard every time exactly the same massage, that's exactly this, that's more or less the same for every person, and not designed to meet a person where they are for that day.
And their pain.
And their pain, right. What kinds of results might we see if someone actually received a tailored massage from someone who was skilled in helping people deal with chronic pain?
Right.
And so that's sort of the difference between an effectiveness study that asks the question, does it work, and an efficacy study that asks the question, will it work in the most ideal possible circumstances to get a clear answer? This
is a pickle one, because this isn't the most ideal situation.
Right. That's my point.
Right. This isn't an efficacy trial, but yet they have a protocol that is set up as efficacy. So that's a really interesting thing. They have pragmatic approaches from the population and all these things, but
not from the massage.
Right, they're not tailoring the massage. So actually, I think, and they also talk about how the next studies need to be for just for back pain or just for this kind of pain, and I don't know about that. I think that if you bring in, you say, if you're here for pain, you can come and have 8 or however many sessions you're going to have, and your massage therapist is going to address your pain cycle. And I think that if we're going to look and see if massage, as practiced by massage therapists, is effective, you don't necessarily take out that that therapeutic relationship that can develop. And they specifically set this protocol up to discourage that to happen.
To discourage a personal relationship between the person and their therapist. Right.
So it wasn't just, you weren't necessarily assigned to a therapist. And it could be a different therapist that came in. It was just that men worked with men and women worked with women.
Yeah. So what if you got one person to see you all the way through who was knowledgeable and skilled about your particular issues? Right.
And that, to me, would actually be more of an efficacy type trial.
Oh, yeah. No, I totally agree. I totally agree.
But yet it's still having a lot of these pragmatic sort of pieces to it. So it's a really interesting conundrum that massage and bodywork face here with efficacy versus effectiveness trials, and where do we go from here?
Right. Yeah, because this researcher, who's in Portland actually, is interested in sort of keying in on different sources of pain, and we probably agree on this, that she'd probably get clearer answers if she keyed in on different kinds of, or different flexibility, versatility in her massage therapists. Right, and in that protocol. And so, the study that was done at the University of Kentucky that actually allowed massage therapists to develop their own treatment plan. And it was looking at, is massage as practiced in the real world effective in this very complex patient group? And so ours was chronic low back pain, and this is an exceptionally complex patient group, right? Oh yeah. So I was really excited to see this piece come out. I, like you, at first was going, oh, but then when I started really looking at it, I'm like, no, there's a lot of good pieces coming out of this. And it just depends on the lens through which you're gonna look at it and what the next steps are. So that's a good way to emphasize a point that we make frequently, which is that a null finding is not necessarily bad news. Right. A null finding, a finding that you didn't get the strong responses that you thought you would, can sometimes really lift the lid on some really important information. Right, and this is also something that having research efficacy, so knowing, or literacy, literacy is so very important. Right. To know that, so if somebody were to come up to me and say, oh yeah, well that study came out and said that massage isn't effective for people who are opioid dependent. Okay, well wait a minute, and being able to qualify that. Right. From the standpoint of, well, it was in this population, this was the type of massage that was being used. It's not appropriate to say massage would never be beneficial in this group. And which is why it's so important to read further than the abstract. Yes. And further than the headlines. Yes. Yeah, and think about it critically. Yeah.
Yeah. Great points. Great insights. I hope we see more research on this population in the future. That's great.
Oh, me too, Michael.
Well, awesome discussion, both of you. Thank you so much today. Really appreciate it. So, is it okay if we wrap up? Yeah. All right. I think we're good for today. So. Thank you so much, everyone, for joining us, as always. We do encourage you, just like Ruth said, that we do encourage you to read beyond the abstract by downloading the entire article at ijtmb.org. We will link to it below the video, and if you're listening via audio, just go to ijtmb.org and search for opioid. They'll probably find the article. There's many authors. I won't list all the authors, but that should probably pull the article up for you. So go ahead and download the whole thing and take a look. There's a lot of good stuff there. So,
well, definitely put a shout out to Dr. Wiest. Am I saying that?
Yeah, sure, go ahead.
Yeah. So to definitely plug that. Dr. Wiest was the lead author on this.
Okay, great. Thank you, Nikki. Appreciate it. All right. Well, thanks as always, everyone, for joining us. And Ruth and Nikki, thank you so much for being here as always. So until next time, we'll see you on Research Perch. Thanks so much. Have a good day.
Bye, Michael.
Take care.
Thank you for joining us for this episode of Research Perch. Please send feedback or questions to perch@massagetherapyfoundation.org. See you next time.